There's more, but this is a good place to start. And you can use some of this information to carry on with other infectious diseases. So starting with meningitis, which is, really the most common of all of the CNS infections that we are going to see. So meningitis, inflammation of the meninges, part of the central nervous system. Most meningitis is viral, but then it's bacterial and fungal. Meningitis is extremely, high risk. It's awful to have significant morbidity and mortality with this disease. The mortality, even with good treatment, is as high as 30%. That's not even suboptimal treatment. That's with good treatment, 30%. The causes really depend on the patient's age, what they're vaccinated, if they have other comorbidities. The most common community acquired, like what you would see the most, would be strep, pneumonia. Young adults, children will get the Neisseria meningitis. So here in the States, that's something we see, like we associate that with college age kids or people living in close proximity. And there is a vaccine for that now. Listeria meningitis is really common in infants, some immunosuppressed, but infants, and then nursing home patients. And then tuberculosis meningitis is the most common cause of chronic meningitis in the world and will be the most common cause of meningitis in Vietnam. Though bacterial meningitis is far more significant and something that we're really looking out for, remember that aseptic meningitis is actually the most common form of meningitis. So this is when there's an inflammation of the meninges without the actual bacterial growth. So that's, you do a CSF and nothing ever grows. It's usually a virus that is undetected, but it can also be caused by different medications. Some of those chemo drugs will cause this, cancers, and then autoimmune disease. For viral meningitis, the most common cause is enterovirus. So that's good to remember. And then other causative viral pathogens could be, you could get mumps, choriomeningitis, or HSV. And then in your immunosuppressed patients, CMV, so cytomegalovirus, and varicella are the most common. There's also fungal meningitis, which is pretty rare, but it's much more common and something to be aware of in your HIV patients that have low CD4 counts and high viral loads. And then patients that are severely neutropenic or have history of transplant, you can be concerned for Aspergillus and Candida, as well as cryptococcal meningitis, just like in the HIV patients. And then there's also mucormycosis, which can affect diabetic patients, so kind of a unique one. The story with this is typically a patient will get a sinus infection or be swimming in some water, and then it ascends, goes up into the CNS and will cause this infection. So the presentation for meningitis, depending, it varies a little bit depending on if it's viral, bacterial, or fungal. So when we're talking about bacterial meningitis, it usually comes on much quicker. So the onset can be over several hours, in less than a day, usually 12 to 24 hours or less. And the symptoms, the triad of symptoms, is usually headache, fever, and altered mental status. But like you see, the most common is headache, then neck stiffness, then fever, then altered mental status. About a third of patients that have bacterial meningitis will have a focal neurological deficit. So they'll have a blown pupil or they'll have a facial droop, something that will hint you to there being something going on within the brain. For pediatric patients, older patients, immunosuppressed patients, their symptoms just can be nonspecific. It's a lot harder to diagnose meningitis because it's just not as clear. For meningococcal meningitis, about 63% of them will have this distinct rash. And this is a good one to know. If you have a patient that's altered with this rash, be highly concerned for meningococcal meningitis, the one that's up on the screen. The nuclear rigidity, just remember it's not very sensitive, but it is a bedside test you can do if you have any concern. So the Koenig sign, you contract the hamstrings. If So if you extend the knees while the hip is flexed and the hamstrings will contract. And then there's the Brudzinski sign, and you flex the hips and knees, and then the neck comes up. So really the best way to test this is you like curl the patient into a ball. And if their legs straighten when you curl their neck up, then that usually means that they have some nuchal rigidity. Viral meningitis, like I was saying, they can have these symptoms, but it's usually they're not going to be as ill. So they'll have a more mild headache or more mild fever. Altered mental status is less likely with viral meningitis. If you see that, I would be concerned for bacterial meningitis as well. And then with viral meningitis, you can also present with the symptoms of the virus that led to the meningitis. So with enterovirus, runny nose, stuffy nose, cough, or vomiting, those sorts of things. And then with fungal meningitis, just remember that can be chronic. So they could have had these symptoms for a month or several weeks. So don't let that fool you, the onset of time, to not look into this as a diagnosis for when somebody comes in. So the typical workup for meningitis, I mean, the biggest thing you're going to need to do is get cerebral spinal fluid, or the CSF, by doing an LP and getting that. I'm not sure if you guys are the ones doing that in your facilities, or if you have your radiologist do them, or neurosurgery. Every place is different. In the US here in the ER, it's our responsibility, because the quicker you can get that fluid, the better. When you do get it, just make sure you order as many tests as possible, because it's an invasive procedure and you don't want to do it again. So you do want to look at the opening pressure, and then you're going to order a gram stain, a cell count, glucose, protein, basically as much as you can get cultures from that. If you have the ability to do viral testing, that's great. If you have the ability to do fungal testing, like just having somebody look under a microscope, they have pretty distinct looks. And then with Cryptococcus, there's an India ink stain test that you can do that is distinct for that one. Obtaining a CT head before LP, there's some controversy around it, because the test answer is get the LP as soon as possible. Don't do the CAT scan. In practice, if you're highly concerned for meningitis, it usually means that you're dealing with a sick patient, and it can be tough. I would say much more often than not, I'm getting the CT first, because you're doing a physical exam and it's not always reliable, and people that have this are ill, and you can get a CAT scan pretty fast, especially if you're worried. Someone you call over to CAT scan, you get that CAT scan done within 10 minutes, and you can be setting everything up. Doing the CAT scan will help you rule out other causes of this. So like the brain abscess, or, like a severe encephalitis, something that would show up that would lead you towards that. The biggest thing you're looking for is something that's causing increased intracranial pressure, because if you do that, say somebody has a brain abscess or a mass, and you do the LP, you can risk a herniation, which would obviously be catastrophic. So in my personal practice, I usually take the 10 minutes and just get a CAT scan as quickly as possible. That being said, there are guidelines. If you want to follow those guidelines, or figure it's harder to get a CAT scan, if it is going to be a delay in CAT scan, the ones that you can just go ahead with would not be these. So here's the indications for always doing a CT before the LP would be if they're over 60, they have severe altered mental status, they do have one of those focal neurological deficits, if there is a history of any CNS disease, so like somebody they have brain cancer, or have had a recent stroke or infection, other type of infection, if they're immunosuppressed, so an HIV patient, a transplant patient, if they have papilledema on exam, and if they've had a seizure. And so don't just get the scans on those ones, but if you might, like I said, my practice is usually almost always to get the CAT scan. A CT, if you have available an MRI, if you want the MRI, I would not do before you do an LP. That takes a long time. They're on the table for a long time. But if you've done it and you know they have meningitis, you can do an MRI afterwards to make sure they don't have any complications or some other more subtle findings from the meningitis. If somebody's altered, that's probably a path I would go down, or they can do that on the floor as well. And then you're going to want to order all the other lab tests, obviously, and for sure blood cultures, because a high number of these patients with bacterial meningitis will have a bacteremia. So they'll have bacteria in their blood as well. So here's a chart that you can use for CSF interpretations, and there is no harm in just like looking something like this up. They're all over the internet. If you do it, if you're unsure. For me, the most important thing to know is just looking for bacterial, and the other ones you can take your time and really think through those and get infectious disease. But looking for bacterial, if you see that that gram stain, you notice in the gram stain there's 60 to 90% positive, and then in the WBCs, you're going to have over 500. And then the big one too is the PMNs, which is a type of neutrophils. So the polymorphic neutrophils, there's going to be 90%. So a high number of those. That's going to clue you into if it's bacterial. And then like you'll see you have the high opening pressure. The rest and really if you do you can always look at this chart and pull it up. I think I do every time. So yeah. So the treatment is antibiotics. Obviously, that's the most important thing that you're going to be doing for these patients. Depending on how long it takes you to get the cerebral spinal fluid, you can give antibiotics first. It's not going to be as accurate. But some people say it's okay to even an hour before antibiotics are going to penetrate the cerebral spinal fluid, because they have to go through the bloodstream and then they get to the cerebral spinal fluid. So if you think there's going to be a delay, just start the antibiotics, because this is the biggest thing that will reduce mortality and give you a better neurological outcome. The antibiotic of choice may vary in Vietnam. That's something I would talk to your pharmacist about or your infectious disease specialist. Here, we typically use vancomycin and ceftriaxone as empiric antibiotics. And then you can also consider adding ampicillin if it's an infant or an elderly or an immunosuppressed. Again, you may do something differently in Vietnam because there is such a high likelihood of tuberculosis, so you would need different treatment. So something to consult about. As far as dexamethasone, so steroid use, you would do that if you suspect pneumococcal meningitis. So if you can give that 15 to 20 minutes before. If somebody's really it's usually not going to cause a lot of harm. So if you have a patient that's really ill and you have high suspicion for a bacterial meningitis, I would go ahead and give the dexamethasone with antibiotics or slightly before. If you're diagnosing viral meningitis, it's usually just supportive care. So treating their pain, making sure they're hydrated. You can give acyclovir, and in practice, you're almost always going to give it, but there's actually been no proven benefit to giving it. So there's no change in mortality or how these patients do, unfortunately, when it's meningitis. If it becomes encephalitis, you'll see it does help. There is a benefit. So I would give it. If you know that the patient is immunosuppressed or you diagnose cryptococcus or another fungus, then you're going to need antifungal medicines. It's usually amphotericin B or I can never say this one, but flucitazine, and then an azole. So these ones, again, I would talk to your pharmacist if you're starting antifungals if you can, or an infectious disease doctor, and they can help kind of guide as well. These are sick patients, so make sure you're addressing if they are septic, if they have low blood pressure, they need to be treated just like you would any other septic patient, where you're giving them adequate fluid as well as pressors if needed, monitoring their CVP and doing all those things you would otherwise. If they have had there's any concern for seizures, you may need to get an EEG where they look at the electrical activity of the head, and or start an anticonvulsant medication. So starting the patient on something. In these patients, remember that they are at risk for having increased intracranial pressure. So just like you would if they had a brain bleed and you were worried about increased intracranial pressure, do those things to make sure their blood pressure is good. So if they're not septic, if they're on the other side of things and they have a high blood pressure, treat their blood pressure. Keep the head of the bed elevated, make sure that their temperature is appropriate, make sure that their glucose is good, all those other things you would do. And then, you're going to likely be consulting up people and they're admitted. But if there's concern for increased intracranial pressure or you see a complication on MRI, then you need to get neurosurgery involved. If you diagnosed Neisseria meningitis, remember that everybody who's been in close contact with that patient, especially the healthcare workers, people at home, are going to need a dose of Cipro. And then if you diagnose Haemophilus influenza meningitis, the common one in infants, you give rifampin for the household contacts, and usually that ends up being the people that took close care of that patient. So that's kind of meningitis. Any questions with that one before we move on? Okay. So next is encephalitis, which can be pretty difficult clinically to differentiate from meningitis. This is just an inflammation of the brain parenchyma as opposed to the meninges. It's usually caused by infections, but again, can be caused, just like meningitis, can be caused by some of those same non-infectious etiologies. So malignancy, medications, or autoimmune diseases. Viral encephalitis is far more common. Don't usually diagnose bacterial encephalitis. So this really focuses on the viral encephalitis. And the incidence is kind of unknown because it's not diagnosed all the time and it can go untreated or unreported. The most common cause is HSV encephalitis, and that's from herpes. It's usually from the herpes 1 virus, but it can be caused by herpes 1 and 2. There's a high risk of morbidity and mortality. So if this is encephalitis, remember that you are going to make sure you have to treat with antibiotics, and we'll talk about the treatment. Other viral pathogens that can cause encephalitis are West Nile virus, enterovirus, which is very common, arbovirus, Epstein-Barr virus, adenovirus, herpes, influenza, mumps, CMV, rabies. And then rabies used to be more common, and I'm sorry, I should have looked up. I'm not sure if you guys are still getting it in Vietnam, but most of the country or most of the world, there's not a ton of cases of rabies, but the rabies, that was one of the things that would kill them, would be the encephalitis. So usually encephalitis, it's kind of different how you get it than meningitis, but you invade the host and replicates at sites outside of the central nervous system, and then it spreads in through the brain parenchyma. And then I kind of thought that was interesting, so I added it if you're interested. But rabies, HSV, and herpes, they will start in a distal nerve, so that's why you'd see it like on the face for HSV, and then it travels up into the spinal cord and brain, and that's how you would get it. So with encephalitis, you're usually going to come in with altered mental status. That's the most common and like underlying presentation. But you can also have focal neurological deficits, seizures, altered behavior or personality changes, and then a coma. You'll also see fever with these. So with encephalitis, you are going to need imaging. You're usually going to try to get it. I mean, the gold standard would be to get an MRI. It's going to be the most sensitive and specific for detecting early changes. You can also get a CT, though it's more readily available, and you'll see findings. The very classic one of herpes would be involvement in the temporal lobe, and that's just where it tends to go. So you're going to see it there. You can, on MRI, you would see a hypodensity, some edema, and then hemorrhage even in that area. You can also get an EEG. So HSV encephalitis is going to have a distinct EEG. There is some indication for getting a CSF, but with encephalitis, unlike meningitis, it's going to be harder to like definitively get which bacteria you get, because the your spinal fluid isn't always going to have the infective agent in it. So even if you get the CSF, it may come back negative, and that does not rule out encephalitis. It can rule out a concomitant meningitis, but not encephalitis. You know, a lot of times you are going to be getting this because unless you get CSF, it's hard to distinguish between encephalitis and meningitis before you get imaging. But a lot of times it's going to be negative. You can see some findings with like the slightly higher WBCs and lymphocytes, but most of the time your culture is going to come back negative. And then you can try to look for certain viruses, same as you would if you were looking for meningitis. And again, if you're getting it, I would get all the tests and see if anything comes back positive. But yeah, the treatment for encephalitis is tough. Most of the time it's viral. So if it's viral, if you have any thought, you see anything on CAT scan, you're going to start acyclovir. And a lot of times you're going to start antibiotics with the acyclovir. So the same as you would for meningitis. So ceftriaxone, vancomycin, but then add the acyclovir. In HSV encephalitis, acyclovir does reduce mortality and long-term neurological problems. And it actually has if you treat it, it has pretty good, you can have pretty good outcomes with it, and the treatment is effective. If there is concern for CMV encephalitis, so in an HIV patient, you can change that to different acyclovir. And again, with some of these, you guys may want to talk to your infectious disease people or check with your pharmacy on what the optimal treatment would be, because it might be a little different. Same with meningitis, you make sure you're treating their seizures with anti-seizure medication. And then if you need to, contacting your neurosurgical team. And then the final kind of infectious etiology we'll talk about would be brain abscesses. So a brain abscess is usually going to start as a focal area of cerebritis, and then that will start as it'll develop and become a collection of pus that is usually well vascularized, kind of like an abscess anywhere else in the body, just in the brain. Infection can spread from extension of an ear infection, sinusitis, mastoiditis, or if you've had a recent neurosurgical procedure. So if somebody's had anything done. Brain abscess can be caused by bacteria, mycobacteria, fungi, or parasites. So tuberculosis abscess, something you may see. Among immunocompetent patients, 95% of brain abscesses are caused by bacterial pathogens. So they're usually always bacterial if somebody's getting them. Patients with HIV are more likely to get abscesses from toxoplasmosis or Toxoplasma gondii or Mycobacterium tuberculosis. Fungi are often the source of abscesses among patients with assault who've recently had organ transplants or on anti-rejection medications. And then if you've had head trauma or undergone neurosurgical procedures, usually the bacteria is going to be something that we have on the skin. So Staph aureus or epidermidis or a gram-negative bacilli. 1/4 of abscesses, kind of similar numbers to our skin, are going to be polymicrobial. So just tons of different bugs in there. Most people with abscesses actually have a fairly decent neurological outcome if they're diagnosed and treated appropriately, unless that abscess ruptures. And then usually they do not do well. So this is going to be in the end, this is the neurosurgical issue, obviously, because like an abscess on the skin, it needs to be brain. The triad of brain abscesses is usually headache, fever, and then a focal neurological deficit. So whereas the other ones, it's not as common, focal neurological deficits are pretty common in these because the brain abscess is a space occupying lesion within the brain. So it's going to cause some changes. Most people don't have all three. They're just going to have one. And then the most common symptom is just a headache as the pressure increases, as the intracranial pressure increases. So the deficits that you see are going to be dependent on where the abscess is. So there could be a huge variety of this. One of those could be a behavioral change, if it's frontal lobe or even temporal. If it's in the back, you can have some ataxia or difficulty walking, or any cranial nerve deficits, and then altered mental status. So look for seizures in these patients. Also, almost a fourth of patients will present with seizure. So in the ED, you're going to want to get a CT, and that's with IV contrast. That's to highlight and lighten up the abscess. You're going to get it quickly. MRI is great for this, same as the other ones, but harder to get and harder to get quickly. And these sometimes are sick patients that you don't really want an MRI machine for, 2 hours while you're waiting to diagnose what's going on. Blood culture should be obtained as well. And then LP to get the cerebral spinal fluid is not usually recommended if you diagnose a brain abscess, because there is a mass there. And when there's a mass, you're usually going to have an increase in intracranial pressure, and doing an LP would increase the risk for herniation. If you are worried, you can get neurosurgery involved early, and they can try to get cultures. You can also get cultures if they've had a clear recent source. So they have a big wound on their head that's open to the skin. You can try to get a culture, or a sinus culture. You can try to culture other areas, but that's a little more challenging and may not give you the exact if you're doing something superficial. So with treatment, got to start antibiotics on these patients. Here, again, the recommended empiric therapy for antibiotics would be ceftriaxone, but then adding metronidazole and vancomycin. Not really a huge need to add any kind of steroid. Some people will, because there's some inflammation. So if, like, your neurosurgeon told you to add it, there's no problem with adding it, but there's no proven benefit. If your patient is stable, you can talk to neurosurgery before you start antibiotics. If they look okay, but you happen to diagnose it, because they may want to get a culture of the abscess itself before they start antibiotics. I mean, having somebody that is able to do that fast, I don't see as being that likely, but something to consider. And then, with the treatment, that's our ER. And then obviously consulting neurosurgery and infectious disease. Sometimes if they're small, they will just watch these and see if the antibiotics treats it, and then they don't have to do anything, depending on the location also of the abscess. If it's more superficial, easier for them to get to, they may elect to drain the abscess to try to get rid of the fluid. If it's causing severe increased intracranial pressure, they may force their hand and have to drain the abscess just to alleviate pressure. So it's going to be it's going to vary a lot depending on the size and location of the abscess. But consulting neurosurgery and infectious disease early with these patients is valid. So that is kind of this part. Do you guys have any questions? I know it's a lot of material, something you can look at again, and obviously with the different language, you may take just looking through things again. And then I would highly recommend, as we're talking about this, just maybe running it by your hospital, whichever you talk to, your infectious disease or your pharmacist, especially with meningitis, on what the treatments they recommend are. So those first initial treatments and what you have available for you, just so you have somebody with meningitis, you're not looking it up, trying to figure out, what do I want to give, what antibiotics? And it's just something, brain abscesses, encephalitis, much more rare, something you can take the time to do usually. But with meningitis, it's good to know, hey, what would I give them immediately? But I have some questions, but I would like to see if you guys have questions. Anybody in the chat? Well, that's okay. So I have questions. So why don't you guys can answer in the chat and then we can talk about anything else you want. So a 28-year-old male presents with acute, progressively worsening headache and fever for 1 day. Physical exam reveals a toxic appearing, slightly confused patient with a fever and meningismus. Which of the following is the most appropriate next step in management? A, CT brain without contrast. B, CT brain with contrast. C, lumbar puncture. D, ceftriaxone and vancomycin. Or E, ceftriaxone, vancomycin, and dexamethasone. I am going to say one thing too, pay attention before you answer, is that just imagine on this patient that it's going to take you 30 minutes to get a lumbar puncture, 30 to 45 minutes to get a lumbar puncture. I'm going to wave. I'll also give you another hint that remember, so do this based on the guidelines, not my practice, but we can talk about it. So in this case, hello. Okay. In this case, the answer is the answer is gonna be E. So ceftriaxone, vancomycin, and dexamethasone. And I know I kind of threw you guys with this one because I did say I would get the CAT scan almost every time. And I probably would still in this patient because he's confused, has this altered mental status. The textbook answer is to do the lumbar puncture before the CAT scan. So the order in this patient would be E, then C, and then the CAT scan. Or you could do the CAT scan also, but for both of those, I think there's going to be any delay, you want to start antibiotics. So E is always going to come first because you want to start the antibiotics with any type of delay in somebody that looks ill like this. They have this altered mental status already. They've had a fever and meningismus. And as you can see, that it came on fast. So he just got a fever within 1 day. So because it came on really fast, he has a fever and meningismus, you're going to be highly suspicious for bacterial meningitis. So with bacterial meningitis, there's any delay in any imaging, any obtaining any fluid, you want to immediately start the antibiotics. And in this one, because he's 28, so he's younger, kind of in that age group, you're going to be more concerned for an Neisseria meningitis. So you're going to want to give the dexamethasone with that. So ceftriaxone, vancomycin, dexamethasone. Do that and then get the CT with contrast if you want, or the LP. You can kind of, in this one, you could argue either way for the lumbar puncture, then the CAT scan. I would probably get the CAT scan, then the lumbar puncture, but first antibiotics. So next one, which of the following is the most common cause of encephalitis? And A, herpes, B, mumps, C, enterovirus, D, neurocysticercosis, and E, adenovirus. Yeah, so this one, I know we talked mostly about I was just So it's actually enterovirus. We talked mostly about herpes virus, but remember the most common cause of encephalitis is going to be enterovirus. So same as meningitis, actually, for both meningitis and encephalitis, the most common viral cause is going to be enterovirus. And the enteroviruses are going to be Coxsackie virus, which is just more common. So enterovirus. HSV encephalitis is the most common of all the like important to know because it's the most important to treat and most important with your diagnosis is going to be the herpes encephalitis or sorry, herpes. Yeah. But enterovirus is the most common. Next question. So a 68-year-old male presents with a headache and change in behavior. He has no reported past medical history. His family states he is acting much different than normal. On physical exam, he's irritable and kind of has an altered mental status. He's acting funny. He is not oriented to place or time. He lacks meningeal signs, so no nuchal rigidity. His vital signs, he has a temperature of 100.5. His heart rate is 82. Respiratory rate is 20. Blood pressure of 143 over 90. So TSAT is 93%, 99% on Romer. Chest x-ray and urinalysis are normal. Which is the best step in management? A, discharge the patient home with close outpatient follow-up. B, empiric dexamethasone therapy. C, chemical restraint with IV haloperidol. Or D, empiric acyclovir therapy. Do you guys want to answer? I'm going to wait. Get a couple of people to answer. Does anybody else want to answer? Anybody? I'm going to give you guys one more minute because I want to see a couple more answers. Okay, well, we'll talk about it. So this one, yep, Shuni is right. It's going to be empiric acyclovir therapy. So this patient, we can look for some clues in there. He has no medical history that you know of, but he's acting funny. He's got this altered mental status. So his symptoms are altered mental status. That's like the biggest one that they're saying that he has. He does have a fever also because his temperature is 100.5. So altered mental status and a fever, we're going to think about an infection, a CNS infection. He has no meningeal signs, so he probably doesn't have meningitis. There's nothing like they're saying with the focal neurological deficits, so maybe less likely to be a brain abscess, but we're not sure. You know, he's going to need some CT imaging or an MRI to look at his brain, but while we're waiting, this is somebody that we're going to be concerned for a herpes encephalitis because he's got that fever and altered mental status. It could just be any viral encephalitis, but we don't know that it's not herpes encephalitis. Herpes encephalitis, when treated appropriately, it can really reduce mortality and long-term complications. So if there's any thought that a patient like this could have encephalitis, you would go ahead and give antiviral medications. This patient's not super sick, so the reality, like, would you maybe first go ahead and get imaging? Yes. And then would you maybe go ahead and do an LP? Sure. But those weren't options in this one, and it was kind of a question I pulled. So in this one, you would start the antiviral medications. Next one. So which of the following is true regarding herpes encephalitis? A, bilateral frontal lobe involvement is characteristic. HSV2 is most common in adults. Acyclovir reduces mortality. D, most patients recover without neurological sequela. Or E, the sensitivity of cerebrospinal fluid culture is 90%. Let's try some, you guys can try too. It's okay if you're not getting, it's what we're here to learn. So, but just give it a try. Yeah, good. So, this one is the answer C, so it's good. Acyclovir reduces mortality. So in HSV encephalitis, which can be tough clinically from other types, we just were talking about that, the headache, fevers, altered mental status, and it'll most likely be in the temporal lobe. So not the frontal lobe, but the temporal lobe. And then remember, HSV1 is more common to cause herpes encephalitis than HSV2. And then acyclovir does reduce the mortality and the likelihood of having a neurological sequela or a bad outcome. So even if you think it's encephalitis, before you get confirmation that it's herpes, it's okay to start acyclovir because it can really help prevent long-term problems for your patients.
Hey, Claudia, does it matter, like, the mortality if it's less, like, more than 48 hours from symptom onset?
I didn't see anything that showed that. And I would be surprised if that's the case, because encephalitis does tend to present with more prodrome. It's not like meningitis where it comes on super fast. It usually takes time to build up, and diagnosis can be a little more challenging. So I don't think there's a strict, but I'm sure the sooner you give it, the better likelihood you are to have reduced mortality and better neurological sequela. So like the more quickly that it's diagnosed and you start treatment appropriately, the better outcome you're going to have. So I didn't see the data, like specifics of that though. But I mean, in practice, this is a tough thing to diagnose, right? Because somebody comes in with strep throat, they could have a headache and a fever, and some just be lazy and not have a good neurological evaluation. So these are ones do get missed, or that they'll come. I've seen plenty of times where this is like a second ER visit diagnosis, because you're not always imaging everybody if they have a mild headache and a fever. That's not somebody you're necessarily, you treat their fever with Motrin, their headache gets better, you don't image them. And so I think, but just having a higher suspicion for it, especially if somebody has any like a known history of herpes. Unfortunately, same thing though, herpes is really common, a huge percentage of people have herpes and very few people get this. It's a fairly rare disease. Just something to think about though. It's a good question though, Shuni. I have to look it up and I'll get back to you and let you know. I'm kind of curious now. Yeah. Last question. So 30-year-old female presents with headache and fever. Patient has had symptoms over the last week and they are getting progressively worse. Today, her family noticed a major change in her mental status, which is what prompted her to come to the emergency department with her family. On physical exam, the patient has a temperature of 101.5. Her heart rate is 115. Blood pressure, respiratory rate, and pulse ox are normal. So her left pupil is dilated when compared to the right. She has weakness in her arm on the left, and then she has some nuchal rigidity. What action should you take first? So A, perform a lumbar puncture for CSF analysis. B, obtain a CT brain with IV contrast. C, consult neurosurgery. Or D, give 1 liter of lactate ringers. So I'll start talking it through while the rest of you guys give some answers. So remember, this patient, let's focus on some of the important things. They have a headache and a fever and an altered mental status. So headache, fever, altered mental status. It could be kind of any of the things that we've talked about. But on physical exam, she also has a major neurological deficit. She has a pupil that's bigger on the left, and she has weakness on her left. So if somebody has a focal neurological deficit with a headache and a fever, you may be more worried about an abscess or a space occupying lesion, something going on that is in the brain. So if you're worried about that, we know we're not going to do a lumbar puncture because we have to get imaging first. This patient, their heart rate is a little high, but and yes, you may give fluids, but that's not critical right now. Her blood pressure's fine. It's not critical. So in this one, we're worried that it's a brain abscess. And we're going to get a CT with IV contrast first. So worried about brain abscess, something else going on that would be causing that. And with the focal deficit, we want to get it, likely a brain abscess. Don't do your LP first. And then, yes, you can consult neurosurgery first on this one. It's not totally wrong because the pupil is dilated. She has the weakness of the left arm, but that your neurosurgeon is just going to ask you to get imaging. So in this case, you're going to get the imaging first before you consult neurosurgery usually. If there's a delay, like for you guys, if there for some reason is a delay in getting a CAT scan, I don't think it's wrong to consult neurosurgery and just have somebody on board and just see, but you want to make sure you have the imaging. You're also going to start antibiotics on this patient because she has that nuchal rigidity. She has symptoms concerning for meningitis. So I would probably start antibiotics unless you can get the CAT scan fast and neurosurgery consult fast. So get the CT brain with IV contrast in this case. So that is it. And please, does anybody have any questions? And or comments or cases or anything they'd like to share? Well, okay. So review, yeah, please review the slides like I did last time. I can, at the end of this block, or even I can try to do it sooner. This time I'll be happy to share my presentation with you guys so you can go back and look through anything and talk to your people about figuring out what antibiotics, and I'll text you guys. I'll let you know about the encephalitis and acyclovir for herpes encephalitis and get back to you on that. Next week, we're talking about necrotizing fasciitis. So just skin diseases, skin infections. And I will send out you should have the reading, but I'll send out the questions and a Zoom link in a few days. So thank you very much. Bye. Thank you, guys.
Yeah, sure. I guess before everyone goes, yeah. Perfect. Looking forward to it. Thank you for having me.
Wait, real quick, real quick, Dr. Dyke. Shuni, did you want to say something?
Yeah, I just thought I'd introduce myself. I mean, I
Yeah.
think most of you guys have know me. I've joined you guys for a couple of these, but I'm Shune. I'm one of the second year ER residents. I'm gonna be there from March 13th to the 31st. Yeah, I've been to Vietnam a bunch of times. I think this will probably be like my 7th time in Vietnam. I really like the country. So really excited to meet you guys.
He'll be a great resource for you guys and be able to pass on a lot of great skills that he has, and will be really valuable and good learning experience for everybody. So it should be great.
Yeah, I'm hoping to learn
I'm
a lot
jealous.
from you guys.
I'm jealous. Yeah. Okay. Great. See you guys next week. Bye. Bye.